I am Dr. Saman Renuka, consultant orthopedic surgeon from Sri Lanka. We are going to talk on non-scaphoid carpal injuries. Carpal injuries can be bony, ligamentous, or combination. We have to look for carpal bone fractures because some fractures are not obvious in standard X-ray views. If we suspect, we have to order special views or special imaging like CT or MRI scanning. Carpal bone fractures account for around 8 to 19% among all hand injuries, and majority are scaphoid fractures. And the second most fractured carpal bone is the triquetrum. It is important to identify carpal bone fractures at the early setup. Then we can start early management, and depending on the success, there is a high chance of early mobilization and good functional recovery of the wrist. Triquetral fractures are the second most common carpal bone fracture, and that accounts for around 15% of all carpal fractures. It can be associated with distal radius or ulnar fractures and perilunate dislocations. Triquetral fractures can be dorsal cortical fractures, body fractures, or palmar cortical fractures. Dorsal cortical fractures is by far the most common fracture. That can be avulsion, shear force, or impaction. It is interesting to identify the pooping duck sign in the lateral view of the wrist X-ray. When we order X-ray, we can ask for AP, lateral, and 45-degree pronated oblique radiograph of the wrist. There will be swelling and point tenderness on palpation directly over the triquetrum in this patient, where we can see the swelling. Generally, it needs a high amount of injury to cause triquetral body fracture. Fractures of the body of the triquetrum are occasionally seen with perilunate fracture dislocation, and there are 5 categories in triquetral body fractures. Palmar cortical fracture is an avulsion type of injury. The fracture occurs at the insertion point of the ulnar triquetral ligament and the lunar triquetral interosseous ligament. Dorsal cortical fractures are most of the time managed with wrist splint or cast for approximately 4 to 6 weeks. Immobilization is recommended because of the importance of 2 dorsal ligaments to proximal row stability. MRI scan can be obtained to identify intercarpal ligament injuries or occult fractures. Body fractures are managed with open reduction if the fracture is displaced or if there is instability. Open reduction can be done through dorsal ulnar approach radial to the extensor carpi ulnaris tendon. Fixation can be done with K-wires or interfragmentary screws depending on the fracture fragment size. If there is a ligamentous injury, suture anchors can be used. Non-union of the triquetral body fractures are rare. If it is symptomatic, bony fragment can be excised. Other complications are persistent carpal instability and pisotriquetral arthritis. Treatment for pisotriquetral arthritis is excision of the pisiform bone. Then we look for hamate fractures. Hamate is a triangular shaped bone with hook and body. Most of the fractures are hamate hook fractures. Those are secondary to falls. We can look for point tenderness if we suspect hook of hamate fractures. If there is chronic hamate hook fracture, patient may complain paresthesia or weakness in the ulnar nerve distribution. This is a patient with hook of hamate fracture. There's a special examination, that is resisted flexion of the ring and little fingers. In this provocative test, there will be pain when the tendons are compressing over the hook of the hamate. Hamate body fractures can be associated with dorsal fracture dislocation of the fourth and fifth metacarpals. We can see relative shortening of the fifth metacarpal bone in this X-ray. Hamate fractures are best managed conservatively. If there is painful non-union, the fragment can be excised. If the fracture is associated with the base of the fifth metacarpal bone, fracture can be reduced and percutaneous transfixation KYS can be utilized. If patient undergoes open reduction, that is through the dorsal approach. Fixation can be done with KYS or screws. Excision of the hook of the hamate non-union can be done through Palmer approach, either carpal tunnel or ground canal approach. Capitate fractures are very rare and rarely occurs in isolation. It is most of the time associated with scaphoid fractures or transscaphoid transcapitate peroneate dislocation. Body fractures can occur in hyperextension of the wrist, axial load, or direct blow. Here we can see the 180-degree rotation of the proximal pole in hyperextension injuries. Capitate is rigidly anchored to the base of the third metacarpal bone. So it makes the central column of the hand and wrist. So fractures of the capitate are most of the time associated with transscaphoid peroneate fracture dislocation. Here we can see transverse body fracture in the capitate. Non-displaced capitate fractures can be managed with short arm thumb spike carcass for 6 to 8 weeks. If the fracture is displaced or associated with peroneate fracture dislocation, headless screws can be used. And we have to specially be aware of 180 degrees rotation of the proximal pole. Fractures of the body of the lunate usually occurs from distal axial compression at the head of the capitate and is driven proximally into the lunate fossa. We have to look for the carpal instability if there is lunate fracture. If there is no subluxation, no dislocation or instability, those can be best managed with casting. If there is a fracture subluxation, the fracture has to be fixed and the carpus should be stabilized. This is the lunate body fracture, and the Thiessen classification describes the fracture pattern depending on the site of the fracture. So the avulsion fracture of the dorsal portion of the lunate has to be managed as ligamentous injury of the scapholunate interosseous ligament. Non-displaced fractures can be managed with cast immobilization with close follow-up for any displacement. The open reduction can be done for the dorsal fragment or body fragments dorsally, and if there's a volar fragment, that can be fixed with carpal tunnel approach. Osteochondral fragments can be managed arthroscopically or approach into the joint through dorsal incision. Trapezial fractures are very rare, and most of the time that is associated with Bennett fractures or distal radius fractures. Patient presents with trauma to thumb, and we can look for the point tenderness at the base of the thumb if there is suspected body fracture, and there can be point tenderness over the base of the thenar eminence if there is trapezial ridge fracture. So trapezial fractures can be ridge fractures, body fractures, or fracture dislocations. Body fractures can be identified in standard PA, pronated AP, and lateral views. Carpal tunnel view can be ordered if there is suspicion of trapezial ridge fracture. CT scan helps to identify occult fractures and to identify displacement and the size of the fragments. And it is also helpful to identify the articular involvement. This is displaced body fracture. Ridge fractures occurs most of the time on fall on outstretched hand, and this is a kind of avulsion type injury due to the insertion of the transverse carpal ligament. Non-displaced body fractures and ridge fractures can be managed with thumb spica for 4 to 6 weeks. If the fracture is displaced, fracture can be fixed with interfragmentary screws or K-wires. If there is associated OA in the base of the thumb, primary trapeziectomy can be done. This X-ray shows with percutaneous fixation of the trapezium, and the other one shows interfragmentary screw compression of the trapezium. Pisiform is a sesamoid bone of the flexor carpi ulnaris tendon that can happen in direct trauma or fall on outstretched hand. Patient may complain ulnar side wrist pain or grip weakness, and we can look for the tenderness or the base of the hypothenar eminence. Standard PA or carpal tunnel X-ray views can show pisiform fractures, and if there is suspicion, we can go for CT scan. Pisiform fractures are best managed conservatively. Patient can undergo short arm cast application with 30 degrees of wrist flexion and ulnar deviation for 6 to 8 weeks. Most of the fractures will heal. If there is painful non-union or post-traumatic osteoarthritis, excision of the pisiform can be done without reduction in power grip. Trapezoid fractures are very rare in isolation. In summary, we have to look for carpal bone fractures, and then we have to identify whether it's stable or unstable. If it is stable, early mobilization is very successful, and the patient should be reassured that the pain will be there for several months. If there's painful non-union, fracture fragment can be excised. Thank you.